Good morning, ladies and gentlemen. Welcome at the topic endocrine glands. Endocrine glands are part of endocrine system, which is one of two regulation systems of the human body, together with the autonomic nervous system, but it's phylogenetically older than the latter one. It regulates activity of other system, so they could not react to changing requirements of outer and inner environment. Yeah, so they maintain so-called homeostasis, which is an equilibrium of the inner environment. Yeah. They do not originate from anatomically similar structures, so they derived from developmentally very different structures. They are derived from endoderm and endoderm, ectoderm and endoderm. And as these glands, they secrete into intracellular fluid, and then it gets into blood. So there are no ducts from these glands. That's why we call them endocrine, so a secretion inside. And nearly all organs and tissues of the human body, they can produce a hormone, but the organs which are specialized for that we call organs of the endocrine system. I said hormone, and hormone comes from Old Greek word hormon, which means to arise. And hormone is a chemical substance which serves as a messenger. It is produced by endocrine gland or a cell, and it's transported by blood to a target organ. And it can be either protein or amine or a steroid. So we have different kinds of them, and based on the structure, also the function is a bit different. Clinically, these glands are also very important as we can suffer from either hormonal excess or from a hormonal deficiency. Yeah, the excess is done by gland overproduction due to overstimulation or a tumor, or it can be secondary to excess production of a trophic substance. That means that it can be overstimulated by a gland which is located in the regulation system a level above. On the contrary, hormone deficiency can be caused by, again, primary gland failure. That means hypofunction or missing function, or the organ can be iatrogenically removed, or secondary due to the lack of stimulation by a trophic substance coming from the above level, or for example, in case of diabetes, by resistance of the target organ to the hormone. The history of endocrine glands is very interesting, and Thomas Wharton first described them in detail in a book called Adenographia, so that means book on glands. And then the function was for the first time well defined by Ernest Hurley Starling, who proposed a general scheme of endocrine secretion, and he applied the already existing word hormones. The endocrine system is arranged in a series of glands, but it can also contain disseminated cells, mainly in GIT and respiratory systems, and it also can cover some neuroendocrine cells in hypothalamus. So here is just an overview of the main endocrine glands. So we start to talk about the hypothalamus and pituitary gland, which forms one axis. Then we talk about thyroid and parathyroid gland as they are close to each other. Then about suprarenal glands. Then the pancreatic eyelids of Langerhans, which are spread within the tissue of exocrine pancreas. And finally about the pineal gland located in brain. So the most important part of the whole system is hypothalamus and hypophyses, which are closely interconnected. So we call them hypothalamo-hypophyseal axis. As you can see, we find them basally on the brain. So first, we start with pituitary gland or hypophysis. Yeah, hypophysis means it is located below the brain, and pituitary gland means that it produces a pituitus, which means a mucus, and already Galenos thought it forms a mucus for a nasal mucosa. Yeah? But as late as Kachlík came with explanation of the function that it is the main conductor of the endocrine system, a prime minister, which is of course regulated by brain, by hypothalamus, but the main function is to regulate the other endocrine glands. And it's connected to hypothalamus. And hypothalamus is a basal part of diencephalon. It's a visible part of diencephalon. And it consists anatomically from optic chiasm and infundibule and corpora mammillaria, the mammillary bodies. I will show you later. And it also forms floor and inferior lateral walls of the third ventricle of the brain. And the function, it's the highest autonomic center. So it collects information from the body and the surroundings necessary for maintaining homeostasis. It's also part of the limbic system, but it is the manager of other endocrine glands via hypophyses. Yeah? So, infundibulum and pituitary gland or hypophyses are the endocrine parts of hypothalamus. And here on this figure, we can nicely see where the hypothalamus is located. It is the basal part of diencephalon below the anterior commissure and below the hypothalamic groove, extending from optic chiasm to a mammillary body and forming the lateral inferior walls and the floor of the third ventricle, which extent of the third ventricle is also here to the thalamus. And here, this we call infundibulum, and we can see the pituitary gland hanging down from infundibulum. Here on the brain section, we can highlight where we find it. So this is the anterior and posterior lobe of pituitary gland. Then this part we can call infundibulum. And approximately this area then we can consider to be hypothalamus, yeah, from the optic chiasm to mammillary body. You can see that the colors of the anterior and posterior lobe of pituitary gland are different, as the posterior part is derived developmentally from hypothalamus. So that's the median section of the brain. And then when we perform a frontal section, we can see this darker area, which is hypothalamus, and the third ventricle, the pituitary gland with the two lobes. And you can see that each lobe is connected to different part of the hypothalamus, and the hormones will be transported also differently. And you can see that we have here some specialized nuclei which will produce the hormones. So what are these nuclei? These nuclei are, we can divide them into two. The first group forms so-called paraventricular and supraoptic nucleus. We will talk about these nuclei in detail in CNS, but according to the position lateral to the third ventricle and above the optic tract, we can call these nuclei, and what they produce, both of them produce oxytocin and antidiuretic hormone or vasopressin. The function of oxytocin is on smooth muscle of uterus during delivery and myoepithelial cells of mammary gland during feeding milk to a suckling, so it helps for ejection of the milk from the mammary gland. And the antidiuretic hormone, or vasopressin, the main function is for reabsorption of water in distal and mainly collecting tubules, yeah, by aquaporins. But also it constricts vessels, so it's called also what used to be called vasopressin. Yeah? These two are peptides, they are oligopeptides, so their duration of their function is quite short, only in minutes. Then the other part is the arcuate nucleus and what is close to arcuate nucleus. What is close to arcuate nucleus can be, for example, lateral hypothalamic nucleus and preoptic area as well. But mainly we talk about arcuate nucleus and its surrounding, and it produces hormones which regulates pituitary gland, the anterior lobe, and we call them liberins and statins, as they stimulate or they inhibit the production. Yeah, we'll talk about this in a minute. So we have two groups of nuclei, and when we return to the figure here, we can see how the arcuate nucleus and its surrounding produces these liberins and statins into the anterior pituitary gland via blood, and how paraventricular and supraoptic nuclei, they produce their hormones, their oligopeptides, and they are transported via axons into the posterior lobe of the pituitary gland. So a different way of production and different way of transportation. So here we can see again how they are transported. So the paraventricular and supraoptic, we can see nicely the axons of these neurons, and via axonal transport they get into the posterior lobe of the pituitary gland, where they are secreted into blood. And the arcuate nucleus, its axons produce or release the hormones into the blood, into the capillary system, and then it's taken by venous blood into the second capillary network in the anterior pituitary, anterior lobe of the pituitary gland. So two different ways. So the arcuate nucleus serves for production of these liberins and statins, and it is released at so-called median eminence. And at this median eminence is released into a capillary network. And these hormones are liberins and statins. So what they do, the liberins, they serve as stimulating hormones. So they stimulate corresponding hormones of anterior lobe of pituitary gland, and we have 5 of them. And we have somatotropin releasing hormone and prolactin releasing hormone and gonadotropin releasing hormone, then thyroid releasing hormone, and corticotropin releasing hormones. And then we have 2 statins only, and we have somatostatin for the somatotropic hormone and prolactin inhibiting hormone, which is the same as dopamine. Yeah, and it is then important in clinics that it's the same substance. So that's it. That's for hypothalamus, and now hypophysis. Hypophysis is a double gland. We have already mentioned that is composed of 2 lobes. That means from 2 different tissues, coming also from 2 different embryological backgrounds. The anterior lobe is sometimes called adenohypophysis, and it is a real gland, adenos. And the posterior lobe is called neurohypophysis, and it is composed of axons and glial cells. The whole pituitary gland is located within the Turkish saddle of the sphenoid bone, And we know that if we have here any pathology, it can be surgically approached via nasal cavity and via sphenoidal sinus. So we call it transsphenoidal surgical approach. It is separated from the brain by dura mater, and this part of dura mater we call it diaphragm, cellular diaphragm, diaphragma cellae. And of course, it has to be connected somehow, and the connection is called infundibulum, infundibule, yeah. And the opening of the diaphragm is called a foramen of diaphragm of Pacchioni, yeah. So that's the name of the opening, and we can imagine that the opening would be somewhere here, yeah, and the diaphragm will then separate the sella turcica, Turkish saddle, from the rest of the cranial cavity. And here we can nicely see how the anterior lobe here is composed of more parts. This part is the main part, and we call it a distal part. Yeah. So the main part here is the distal part, 75%. Then we have very small intermediate part, which is rudimentary. And then we have this, which we call tuberal part. Why it's called tuberal part? As this part of hypothalamus is called tuber cinereum, which means an ash-colored tuberosity. Yeah, sinus cineris is ashes. So tuber cinereum, that's why it's called tuberal part. And then the posterior one, you can see the posterior lobe or neurohypophysis. It's directly connected. It is a pouch of hypothalamus. Yeah, and the connection is called infundibule. Okay. How large is hypophysis? It's very small. It's less than 1 gram, usually 0.5 grams. But during pregnancy, it can be enlarged 3 times. Yeah, and the dimensions are 1 to 1 centimeter, and it's ½ centimeter thick anteroposteriorly. So we have talked about the division. So again, to repeat, the anterior lobe, or sometimes called adenohypophysis, is composed mainly of the distal or sometimes principal part, which is the largest part. Then between these lobes, the intermediate rudimentary part, and a tuberal part, which is cranially just between the hypothalamus and hypophysis. And then the posterior lobe, sometimes called nervous lobe or nervous part, as it's a pouch of hypothalamus, and the connection between the hypothalamus and pituitary gland is called infundibule. So that's for the anatomical terminology. Now you can see here the different kind of blood supply. Here you can see that the neurohypophysis, the posterior lobe, has got this inferior hypophyseal artery, but the posterior lobe is supplied by superior hypophyseal artery and by 2 capillary systems. When we have 2 capillary systems, we call it a portal system. Yeah, why portal system? We can see a similarity to intestinal and portal capillary network. Yeah? When we have a blood supply to the intestine, then it's drained by veins into portal vein, and then the portal vein branches into capillaries, sinusoids of liver, and then it forms hepatic veins and drains into inferior vena cava. So you have 2 capillary beds in a series. Here we have also 2 capillary beds. One is in hypothalamus and the other is in anterior lobe. So the blood supply works from superior hypophyseal artery, which is branch of the very last segment of anterior of the internal carotid artery. We call it the communicating segment or part. So it supplies hypothalamus, where it forms the primary capillary network. And this primary capillary network receives the hormones from arcuate nucleus, statins and liberines. Then it travels by veins called portal hypophyseal veins. Then it comes to adenohypophysis and forms the secondary capillary network, where these hormones are absorbed into the tissue of anterior lobe. And of course, hormones of the anterior lobe, which are produced there, are then secreted into the capillaries and drained by hypophyseal veins into cavernous sinus. Yeah. So then do not forget, we have two capillary systems in a series, so we call it hypophyseal or hypophyseal portal system. For the posterior lobe, it's very easy. We have inferior hypophyseal artery, which is branched from the cavernous segment of internal carotid artery, and then it's drained to hypophyseal veins and to cavernous sinus. So quite complicated blood supply, and you can also see here again, and this is from the other side. So this is anterior pituitary, and this is posterior lobe of the pituitary gland. Yeah, and you can see how we have two capillary networks, first and second, and how it works in the posterior lobe. In posterior lobe that we have from paraventricular and supraoptic nuclei, that it travels via axons, and then it's secreted directly into the blood here. So please remember this difference between the anterior and posterior lobe of the pituitary gland. As for the development, you should remember that these two lobes are derived from different layers. The anterior lobe comes from ectoderm. So it comes from a stomodome. From the roof of the stomodome, there's a pouch, and this pouch grows towards the diencephalon. Yeah? When it means the diencephalon, it is then separated, and its anterior wall more proliferates, and usually no connection between these two structures then exists and persists. So they are totally separated in quite rarely we can have something which we call canalis craniopharyngeus, which is a remnant of this communication and can persist. This pouch is called the pouch of Rathke. Yeah, that's the term which is used for the ectodermal pouch of the roof of the stomodome, forming the anterior lobe. The posterior lobe it's very easy. It is part of the hypothalamus, so it has to be derived from neuroectoderm. So it comes from the prosencephalon, from the diencephalic base, and the glial cells are then transformed into so-called pituicytes. So pituicytes are the glial cells of the posterior lobe. So these two pouches are developed here. So the neuroectoderm then here induces the ectoderm to be produced, and then these two pouches grow to meet, and then they form the pituitary gland. And here you can see the remnants coming from the roof of the stomodome. Yeah. So here we can find some remnants of the tissue of the anterior lobe, and the canal produced here is the craniopharyngeal canal. So again, here we can see the Radke's pouch in the roof of the stomadeum, and the mutual induction with the pouch for the posterior lobe, and formation of the pituitary gland, and here then fading out of the communication of the stalk of the Radke's pouch and the craniopharyngeal canal. And here on scanning electron microscope figure, we can nicely see how it's produced. And this is the Radke's pouch here, and from the other side, the diencephalic pouch here. Yeah. Okay, let's talk about the histology. It's a gland, and as such, the cells forms here cords and nests, which call them in Latin chordae and racemi. In all endocrine glands, we have fenestrated capillaries, yeah? And these cords and nests are composed of 4 types of cells. These two are the active ones. So we have acidophilic and basophilic, and you can see that we have more of the acidophilic, but the basophilic, then we have 3 types, and acidophilic 2 types. Half of the cells are chromophobe cells, yeah, so they are neither acidophilic nor basophilic, so they are quite light, and they have no granules, so they are either already non-active cells without granules, or they are stem cells, so undifferentiated elements. And then the least frequently found population are folliculostellar cells, which produce such a spatial network, and it serves for signaling between the cells and for regulating their activity mutually. So if you look closer to the cells, what they produce. So first, acidophilic cells, which are more abundant. So we call them alpha and epsilon cells. The alpha cells, they produce somatotrophy, yeah, or well known as a growth hormone, GH. And the growth hormone is important for the growth of the human body, not only during childhood, but also for supporting of the function. So if we have not enough growth hormone in childhood, then we stay small. When we have not enough growth hormone in adulthood, we have too much adipose tissue, we have loss of muscular tissue, and problems with the heart function. So it's an important hormone. The epsilon cells, they produce prolactin. So they are multiplied in pregnancy and in lactation, and the prolactin serves for growth of mammary gland and production of the milk. Yeah, so it's very, very important during that time. So these are 2 types of acidophilic cells. And when we talk about the basophilic cells, we have 3 types. Beta 1 cells, they produce ACTH, which is adrenocorticotropin hormone. Yeah, adrenocortico means that it stimulates medulla and cortex of the suprarenal gland. Mainly cortex, of course, mainly cortex. And then these cells, they use a molecule which is called pro-opiomelanocortin, POMC, and they cut this molecule into more hormones. So we have also a melanocyte stimulating hormone, and enkephalin, endorphin, and the lipotrophic hormones as well. But the adrenocorticotropic hormone for suprarenal gland is the most important. Beta 2 cells, they produce thyroid stimulating hormone for thyroid gland. And the delta cells are important as they produce the gonade hormones, so follicular stimulating hormone and lutropin or luteinizing hormone. So the FSH is for Sertoli cells in male and for stimulating of folliculi during maturation of the oocyte. And the LH is for stimulating of Leydig cells producing testosterone and for stimulating of the ovulation in female, in ovary. So these are the 5 types of cells here, and we cannot distinguish the types by hematoxylin eosin. We just can distinguish acidophilic and basophilic. So specifically, if we would like to see the specific cell, we need to use the immunoperoxidase staining. Or, of course, transmission electron microscope, and we can nicely see the granules, different large of the granules of different cells. And this space is called a follicle. Well, then the other parts, not the distal, but the tuberal and intermediate part, they are smaller. The tuberal part, it contains mainly delta cells, but also some beta 2 cells, so mainly FSH, LH production and TSH production. And the intermediate part is the rudimentary one, which can contain some of these follicles here. These cells comes from the trabecules, and we can mainly find here the basophilic cells. These follicles with a bit of fluid are called Radke's follicles, but this is a rudimentary structure, and we find it just between the anterior lobe, which is so nicely colored here, and the posterior lobe, which is quite boring. We said that the hypophysis works as the prime minister. So if we have here the FSH and LH, for example, produced by the delta cells, delta basophilic cells, so they, and in this case, we talk about the male, they stimulate the Sertoli cells for the production of sperms, and Leydig cells for production of testosterone. And then the testosterone via a negative feedback stops this hypothalamus. So this is hypothalamus and the hypothalamic liberine, and the liberine is called gonadotropin releasing hormone. So it inhibits production of this gonadotropin releasing hormone, and this hormone does not stimulate then LH to be produced. When we do not have the testosterone, there is not this negative feedback, and the hypothalamus can stimulate production of all these. So this is just to show you that it is 3 levels. First level hypothalamus, second level is the anterior lobe of pituitary gland, and the third level in this case is testis. The third level. And in physiology you will learn these feedbacks. We have also positive feedback. The positive feedback is produced by estrogens, for example, the positive feedback loop. We have talked about a statin for prolactin, so PIH, which is a dopamine. And here you can see the dopaminergic neuron of the arcuate nucleus. which then sends the dopamine via the portal system to the epsilon cell. Yeah, and the epsilon cell produces prolactin, but the prolactin again serves by a negative feedback back to this arcuate nucleus cells. Yeah, and stops the production of dopamine. And please remember that dopamine is the prolactin inhibiting hormone. The posterior lobe is much easier than the anterior one. Yeah, it starts from the median eminence of the hypothalamus, which is lying just below the floor of the third ventricle, and it continues as infundibule, yeah, into the posterior lobe itself. It is filled with axons of paraventricular and supraoptic nuclei, and we call these axons hypothalamo hypophyseal tract. Yeah, so these axons forms a tract, and these axons are neurosecretory neurofibers. Yeah, they are non-myelinized, very thin fibers, but they are neurosecretory neurofibers. They contain the neurosecretory vesicles, and they terminate at capillaries and produce oxytocin and antidiuretic hormone into the blood. So it's totally nervous tissue. Yeah? So these neurosecretory fibers contains neurosecretory corpuscles, which are called bodies of Herring. And we have talked about the hormones, oxytocin and antidiuretic hormone. The cells between the nerve fibers are glial cells, which we call pituitary, and of course there are capillaries, fenestrated capillaries. Yeah, if you see the histological slide, it's quite boring. You can see nicely the vessels here, and the nuclei are the pituitary, which are the glial cells. So that's all for hypophysis. How we can examine hypophysis when it's hidden inside the bone? We examine it by CT, but functionally, of course, we can check the hormone levels. In case we have a tumor of the hypophysis, these tumors are usually adenomas. That means they are not malign, they are benign, and they can cause two problems. One is they can be hormone active, so they can produce more hormone than usually. Yeah, so we can have, for example, from the epsilon cells, we can have a prolactinome. So this prolactinome can then cause, by overproduction of prolactin, a growth of the mammary gland outside pregnancy and lactation, and can cause the production of the milk. The other problem is that when a tumor grows, then it can compress the other tissue, and the other tissue is then hypofunctional, so it can cause hypofunction of hypophysis, and such hypofunction can be also caused rarely by postpartal bleeding into hypophysis, which is called a Sheehan's syndrome. We continue with the thyroid gland. Thyroid gland is located on the anterior aspect of the neck, and Galenos thought that the main function is to make the pharynx wet. Paracelsus, a well-known figure in the Austria in 17th century, described goiter and cretinism, which is specific for the population in Austrian Alps, mainly due to the lack of iodine. And then Wharton, who wrote a famous book on the endocrine glands, thought it serves as a decoration for the female neck. And at the end of the 19th century, Baumann found out that the thyroid gland contains iodium compounds. Here we can see the gland, how it's located in front of trachea and larynx at approximately at the level of C6 to C7. It is composed of right and left lobe connected via the thin isthmus. So it has got a shape of letter H, but usually the shape is changed by this cranially projecting pyramidal lobe, which is a remnant from development, and it can be present here in 40% of cases. It can be long from 5 to 8 centimeters, and it can be replaced by a ligamentous structure. Then it's called a suspensory ligament, and it can also contain smooth muscle cells. Then it's called a levator of thyroid gland. The gland weight is approximately 30 to 40 grams. So that's basic anatomy. And here you can see closely the relationship of isthmus to trachea, and the superior poles, they are as high as the sides of the anterior aspect of thyroid cartilage. The thyroid gland produces 3 hormones, 3-iodothyronine and tetraiodothyronine, or more often called thyroxine. So T3 and T4, they contain iodium, they are one group, and then calcitonin is another group. The T3 and T4 are produced under stimulation of thyroid stimulating hormone from anterior lobe of pituitary gland. But calcitonin, on the contrary, is produced directly by the gland, by the thyroid gland, based on the levels of calcium in blood. As its gland, it is covered by a fibrous capsule, which sends a septa between lobuli. So it is composed of 2 lobi and then more lobuli, and finally the structural unit is called folliculus, which can be from 50 to even 1,000 micrometers large. The blood supply is complex. From above we have the superior thyroid artery, which is usually branch of the external carotid, but can be branch of the common carotid or from the bifurcation as well. And it is accompanied by superior thyroid veins. Then from below we have inferior thyroid artery, which is a branch of thyrocervical trunk branching from subclavian. Yeah. And you can see that the course of it is first medial and then cranial. And what is important, it crosses the laryngeal recurrent nerve. So during the thyroidectomy, it is necessary to pay attention not to harm the nerve when ligating the artery. Of course, we have inferior thyroid veins, but these veins form an unpaired thyroid plexus in front of trachea, and can be an obstacle during tracheotomy. And they drain into a left brachiocephalic vein in midline. Okay, and then we can have in 2% an immathyroid artery, which usually comes from aortic arch, just in front of trachea in the midline. So again, it is an obstacle for inferior tracheotomy. Usually there are no veins, and there can be a specific veins, middle thyroid veins of Lichacheva, or more often called Kocher's vein, which drains directly internal jugular vein and present in 50% of cases. So we can see it here, and the unpaired thyroid plexus draining into left brachiocephalic vein is visible here, and the middle thyroid vein of Kocher, present in 50% of cases, is visible here. So that's for the blood supply. And now let's talk about the development, which is here a bit complicated again. It is produced from a pouch from endoderm in primitive pharynx in the floor of future oral cavity, where the tongue also develops, and it starts at the 24th day. And it descends. It descends both relatively and absolutely. It absolutely descends, and relatively it gets caudally as the other structures get larger. And it descends through the origin, through the base of the tongue, which is called thyroglossal duct, and it leaves foramen cecum on the dorsum of the tongue. And on the way, there can be left some accessory thyroid tissue, and of course the pyramidal lobe, and if not, there can exist the suspensor ligament or the levator glandular thyroid containing the smooth muscle cells. So here we can see the pouch, the thyroid diverticle, yeah, how then it descends and forms the thyroglossal duct, and it descends in front of the hide bone and then caudally down to the final position. And here you can see the foramen cecum and dorsum of the developing tongue. So foramen cecum is here visible in the midline, and we can see how it descends, but it is not the only part. Another much smaller part which contributes to the development of the thyroid gland is called ultimobranchial or ultimopharyngeal body, and we can see it here. It is derived from the ventral part of the fourth pharyngeal pouch from endoderm, and this is a population of neural crest cells which comes and migrates into this pouch and form this ultimobranchial or ultimopharyngeal body, and this then gets into the developing thyroid gland and forms a scattered population of cells producing calcitonin. For the histogenesis of the thyroid gland, so it's an endodermal tissue, but of course the capsule and the vessels, they come from the surrounding mesenchyme, so they grow inside. And of course the ultimopharyngeal body also in growth inside. And during the 10th week, the cells are divided into the different groups, and we have already the folliculi with a simple flat epithelium, and then the colloid production starts, so the epithelium gets cuboid. So the histological structure, which is visible here, shows the thyroid gland, and here this violet structure is the parathyroid body, and we can see that the thyroid gland is composed of these folliculi, and between the folliculi there are septa, which forms the part of the stroma derived from capsule. So two lobes, then more lobules and folliculi, and the folliculi are lined with a simple epithelium which is cuboid to low columnar, and the epithelium produces a fluid inside the follicle which is called colloid, and the main component is called thyroglobulin, so it's a protein. So the cells which form these are called follicular cells, and then we have parafollicular cells, which are lighter, larger, but much less frequent, and they produce calcitonin. So follicular cells or thyrocytes T, they produce thyroglobulin, which is the protein where T3 and T4 are bound in colloid, and the iodium is then incorporated into them here. And in biochemistry, you will learn such a complex sequence of the synthesis of the thyroid gland hormones. But what is important to remember here, that we need iodine for that. Yeah. Then the follicular cells produce a thyroglobulin, and the thyroglobulin is iodinated. Yeah, and this iodinated thyroglobulin is located within the colloid, and then this iodine thyroglobulin gets back into the cell, and then it's cleaved into T3, T4, and of course the other fragments, which then are broken down, and then T3, T4 are released into circulation and bound to a plasmatic protein, which is called thyroid binding protein. Yeah, but this will be again taught in biochemistry in detail. So the T3 and T4 are the main thyroid hormones, and the concentration in the blood is more T4 than T3, and then T4 is also cleaved into T3, but the activity of T3 is 4 times higher than T4. The function is mainly in a cell, so it activates mitochondria, which increases the cell and tissue basal metabolism. And every tissue and every cell needs these hormones for proper development and growth. Yeah, and we need it mainly for a good neural maturation and for growth of tissues and bones as well. As for metabolism, it activates heat generation, and it activates the absorption of the saccharide in gut. It also elevates the motility of the gut, for example. On the contrary, the parafollicular C cells are the cells which comes from the ultimopharyngeal body. They are located in the follicles at their margins, so they are part of the follicle, but they are not in contact with colloid. They are larger, they are less frequent, and they produce calcitonin. So the calcitonin is produced based on the calcium level in the blood, and the main function is to reduce the blood calcium by larger activity of osteoblasts. So it inhibits the osteoclastic activity. So then the calcium is not produced from the bones. It inhibits the absorption in intestines. So that's why we have lower blood level of calcium. And it also inhibits the reabsorption of the excreted calcium in renal tubules. Yeah. So it's an antagonist of another hormone we will talk about, parathyroid. Yeah, so that's calcitonin. In this hematoxylin eosine histological slide, you can nicely see the follicles, and in follicles the cuboid epithelium. And here, not in contact with colloid, we can see the larger and lighter calcitonin producing cells, so the thyrocytes C, or parafollicular cells, as we call them as well. And And scanning transmission electron microscope shows us the thyroid T cell here, which is in close contact with the capillary here. So a thyroid gland often suffers from pathological disorders. So we can see how we can palpate the thyroid gland from dorsally by both hands, and we ask the patient to swallow, and we can feel during the movement of larynx the thyroid gland well. Then the second option is to use ultrasound, and what is specific is scintigraphy when you use a radioactive iodine 131, and we can see nicely the shape of thyroid gland here. These two dots are salivary glands which also accumulate iodine. So which diseases comes? Of course, they comes with the lack of iodine. So when we have a lack of iodine, which is mainly an endemic disease in mountains, so it then causes goiter. When the lack is from kids, it causes cretinism, so it means problems with the maturation of the brain and low intelligence. That's why we have mandatory screening in all newborns. In adults, it causes myxedem. Myxedem is the edema mainly on legs, on the anterior aspect of legs, but the patients they feel weak, they are sweating, and so the basal metabolism is getting lower. So they are also they have overweight, and it can be caused by autoimmune causes. Then it's called thyroiditis of Hashimoto, and it affects mainly females. On the contrary, there can be an elevated function and hyperproduction, which we call a hyperthyroidism or a thyrotoxicosis. And the most common is autoimmune, again mainly in female, and it's called the disease of Grace-Basedow. And there's a specific sign of that, and the specific sign is orbital. It's called orbitopathy, and the antibodies has a crossed antigen reaction with the retroorbital fat pad, and then this retroorbital fat pad gets swollen, and then the eyes protrude. Yeah, so you can see an exophthalmos, and this exophthalmos then is a specific sign for this disease. Okay, but that is too much of internal medicine. So now we continue to parathyroid glands, which are 4 small bodies located dorsally and often within the tissue of the thyroid gland. As they are very small, they have been first described at the end of the 19th century. But to specify them as an independent organ and independent of thyroid function and its independent development was first discovered by Czech anatomist of German origin, of German Jewish origin, Alfred Kohn. Yeah, and Alfred Kohn was twice nominated for his discoveries for a Nobel Prize, but unfortunately he does not get it. As a Jew, he was transported during the Second World War into concentration camp in Terezín, not far from Prague, but he survived, luckily, and returned. So you can see here 4 parathyroid bodies, and we divide them at the superior and inferior based on the location and development. They are quite small, just 3 to 4 millimeters, and the weight is less than 50 micrograms. The inferior one is usually located below crossing of the inferior thyroid artery and the recurrent laryngeal nerve and the super above this crossing. They both are supplied by the inferior thyroid artery, and usually we have 4 glands, but we can have 1 to 12 glands located in the thyroid gland, but also in its vicinity. So here you can see a operation figure of the superior parathyroid gland. Yeah, located here at the inferior thyroid artery and laryngeal recurrent nerve. Or here we can see 2 of them. Yeah. So the most commonly we find it at the crossing of the inferior thyroid artery and recurrent laryngeal nerve. So it can be located dorsally. It can be located inside the parenchyma or inside the capsule, but it can be located, as you can see, behind the pharynx, even behind esophagus. It can be located inside the cervical extension of thymus or in mediastinum, because the development is closely connected to thymus. It is produced similar to ultimo pharyngeal body and thymus from the third and fourth pharyngeal pouch, yeah, from the dorsal part, as a proliferation of endoderm. And then, of course, the mesenchyme produces the vessels and the fibrous tissues which covers it. And it contains two kind of cells, but only one of them is present here during development. We call them principal. So we can see how they descend from the third and fourth pharyngeal pouch down. And there is important to remember that the third one descends more caudally, so it becomes the inferior, as it descends together with the thymus. And that's why thymus can take it even as low as mediastinum, or the body can be embedded within the cervical extension of thymus. And the fourth one, the fourth pharyngeal pouch produces the superior one. Yeah, it descends not so much as it descends together with the ultimopharyngeal body, which then produces the calcitonin producing cells, the parafollicular ones. So the descent of parathyroid gland is a bit complicated. And what is the function? They produce one hormone, and that's parathormone. Parathormone functions in bone metabolism as antagonist of calcitonin. So it also contains a capsule and a septa, and the parenchyma is composed of cords. And as I said, during the fetal life, we have the principal cells. And then from the 7th year on, we have a population of oxyphilic cells, which are fewer, larger, but we don't know the function yet. Yeah, so maybe another Nobel Prize can be given. So we can see here the scattered cords of the principal cells, and here down the darker, larger, and not so frequent oxyphilic cells. So paranhormone, unlike calcitonin, it increases the blood calcium, and it increases the blood calcium by absorption in intestine, by reabsorption in renal tubules, and by stimulating osteoclastic activity in bones. So if you have patients suffering from osteoporosis, you need to get again more calcium into the bones. So you try to add more calcitonin to stop parathyroid, for example. So remember, parathyroid from parathyroid bodies and calcitonin from thyroid gland, they manage the calcium metabolism. And of course, here we have diseases with hyper and hypofunction. So with hyperfunction, that means more parathyroid and more activity comes usually in adenoma. Yeah. So again, we have non-malign tumor adenoma, but we have an increased blood level of calcium. So it produces pathological calcification in in different tissues, which you can see then on X-rays. It takes too much calcium from bones, but the bones do not suffer from osteoporosis. They suffer from so-called osteodystrophy, which produces fractures, as osteoporosis also does. And the calcification can appear as well in the urine. So the patients suffer from nephrolithiasis. So that's the primary. We can have, of course, some other reasons, like when we have a renal disease, then the kidneys they do not manage to get rid of calcium well, so we have too much calcium. So that's a secondary one, and the tertiary, it comes after successful kidney transplantation. If it is not solved, then we call it tertiary one. So we have 3 levels of parathyroidism, but please remember that patients suffer from fractures and from pathological calcification within tissues. And when we have hypoparathyroidism, it causes a tetany. That means spasms based on low levels of calcium, and this was also proved by Alfred Kohn during his discoveries. Yeah? And this hypoparathyroidism can appear after removal of the parathyroid gland due to cancer of this gland, or even due to the cancer of the thyroid gland. You remove the gland, but if you do not leave there at least one parathyroid body, then the patient suffers from hypoparathyroidism. So if you remove the gland with the parathyroid bodies, then you take the bodies, you cut them in pieces, and you either put them into sternocleidomastoid muscle, or you can put them subcutaneously into the forearm muscles. Yeah, and these small tissues then will work as a proper parathyroid gland, and it can be also examined by scintigraphy. Next gland we are going to talk about is the suprarenal gland, which is sometimes called adrenal gland as well. This gland is located retroperitoneally, cranially to the superior pole of the kidney, approximately at the level of thoracic vertebra 11 and 12, and its weight is between 6 and 12 grams. This is again a double kind of gland. It's composed of 2 different tissues, cortex and medulla, which produces different hormones and also originate from different tissues and layers. The cortex is much larger. It comprises 90% of the tissue, and as you can see, it produces steroid hormones. And 3 groups of steroid hormones. One group is mineralocorticoids, and its major representative is aldosterone, which target tissue is kidney. Then glucocorticoids, there are more of them, like cortisol, corticosterone, and their target tissues are all the other tissues, as the main function is to get glucose prepared for tissues. And then androgens, which are quite weak hormones. The androgen which is produced is dehydroepiandrosterone, DEAS, which is then in peripheral tissue transformed into testosterone. And then the medulla, which is derived from neural crest cells. So it produces totally different hormones, catecholamines, mainly adrenaline, and then noradrenaline, and then adrenaline is transformed by N-methyltransferase. Here we can see the specimens, and you can see that the right and left are a bit different in the shape. The right is triangular, and the left one is more more semilunate. It can you can remember that according to the shape of the organs, they are close, as the liver is also triangular on the right side, and spleen is more oval or semilunate like the left one. Okay, here we can see the close relationship of suprarenal gland to the sympathetic ganglia, which we find along abdominal aorta, and it's due to the common development of the medulla of suprarenal gland and these sympathetic ganglia from neural crest cell populations, as you can see here on this figure. Also, the suprarenal gland is innervated by these nerves. And here in the cadaveric specimen, a suprarenal gland shown here. So it's a primary retroperitoneal organ, the same as kidney. It is in a common cover with the kidney, so it's covered by the renal fascia, and it has the same adipose tissue around. But in case of migrating kidney, the suprarenal gland stays in its position. It does not migrate. Anatomically, we can describe two margins, superior and middle, and two surfaces, anterior, posterior, and caudally the renal surface for the superior pole of the kidney. Although there's a hilum, the hilum serves only for the single suprarenal vein, and the arteries, they enter the suprarenal gland from superior, middle, and inferior aspect, so not via hilum. It is covered by fibrous capsule, of course. Here we can see the different shapes, as I said, triangular on the right side and semilunate on the left side. And on the section, we can see a capsule, and then 3 layers of cortex, and then the yellow one is medulla inside. So we talked about the development, 2 different layers. The cortex is derived from coelomic epithelium, just lateral to dorsal mesenterium, to the root of the dorsal mesenterium. It proliferates and migrates dorsally towards aorta. And what is produced is so-called fetal cortex. And then secondarily from periphery, the definitive cortex is produced, and the fetal cortex undergoes apoptosis. And medulla is derived from neural crest cells populations from the base of celiac ganglion. We call these cells sympathoblasts, and they migrate to the base of the cortex, and then medulla is found inside the gland that the cortex envelops it. So here we can see the area of the development. So aorta and the attachment of the dorsal mesogastrium, so the former root of mesentery, and the coelomic epithelium, and then it grows into the intermediate mesoderm here. And this diagram shows us the pink fetal cortex, which is very large. The medulla gets to the base and then inside. The fetal cortex then envelopes it. And then finally, the definitive cortex is produced from the periphery, and you can see how the fetal cortex fades out. So the capsule, of course, forms septa into the parenchyma, and the cortex consists of 3 layers. Yes, these 3 layers are quite similar to each other. The the largest one is zona fasciculata, fasciculate zone. It forms 2/3 of the gland, and it is also producing then glucocorticoids, which are the first hormone in function from the suprarenal gland, from the cortex. So here on the histological section, we can see the capsule and septa, which enters the parenchyma. Then quite thin glomerular zone, then this fasciculate zone, and then the reticular. So the major marks of the glomerular are these bent or curves cords, which can remind you of glomeruli in kidney. That's why they are called glomerular. Fasciculate, it forms such rows of the cords, and the reticular, they form more a 3D network. And then this is medulla. There is no border between these two. They are just stick to each other. So for the glomerular zone, which forms some 10%, there are, as I said, the curved columns. And of course, the columns are formed by self-producing steroids. And in between, we find sinusoids, as in the other layers as well. And zona glomerulosa produces mineralocorticoids, so mainly aldosterone. And aldosterone is responsible for reabsorption of sodium in exchange with potassium, and not only in a distal tubule of nephron, but also in salivary glands and sweat glands as well. And here we can nicely see these curved cords, which should remind you of renal glomeruli. The fasciculate zone is the widest or broadest layer. They are the long columns of cells, and they again produce steroids, and they are mainly glucocorticoids and a bit of androgens. The glucocorticoids, as I said, serves for assuring a steady level of glucose, and mainly to supply tissues with glucose during stress reaction. Yeah, and here now we nicely see these. We nicely see the cords of the cells producing corticoids, and in between the sinusoids. And then reticular zone, which is again thin, and it forms a network of irregular columns of the cells. And again, within the spaces, there are sinusoids, and there are cells producing steroids, of course, mainly androgens, but also a bit of glucocorticoids. And in androgens, it is the dehydroepiandrosterone. And here we can see this irregular network of columns, and then just next to it is stuck the suprarenal medulla, visible here. So medulla also forms columns, which forms a network, and there are quite large cells, as is visible here, that the cells are larger than the cells of cortex. And they produce noradrenaline, and by the 5-methyltransferase N-methyltransferase, it produces adrenaline under the influence of corticoids as well. But of course, some other neurotransmitters are produced, and in between columns we have a capillary network. So here we can see again a border of the reticular zone of the cortex, and lighter area of columns in medulla. And here we have sinusoids, and then the venules will then form a central vein of suprarenal gland. So for the blood supply, we have already talked about that in vessels, but I found that I have not shared the screen, so I just go quickly through the figures which I have shown before. So we can nicely see here the suprarenal gland sitting on the superior pole of the kidney. And here you can see the shapes. The left side it is lunate and the right side it is triangular. Yes. And here again, the close relationship of left suprarenal gland, right suprarenal gland, and here the sympathetic ganglia. And on this cadaveric picture, we can see the suprarenal gland here. Then this figure shows the surfaces and margins. So we have the anterior, posterior, and inferior renal surface, and superior and medial margin. And hilum is the spot where the suprarenal vein leaves the suprarenal gland. Here on this section, we can see the capsule, which is green, and then 3 different colors of the cortex with zona glomerulosa and fasciculata and reticularis, and what is yellow is the medulla. Here, transverse section of the developing embryo, you can see the dorsal mesogastrium with the spleen forming here, and the coelomic epithelium and the suprarenal gland located in retroperitoneum. This shows us the development of the suprarenal gland. So fetal cortex is pink and the medulla is growing in. Then the fetal cortex covers the whole medulla, and the primordium of definitive cortex is produced, and then it's divided into 3 layers. And at the end, the fetal cortex fades out. And here on this figure, we nicely see the capsule and zona glomerulosa, then the widest zona fasciculata, zona reticularis, and medulla. And here again, the nicely shown glomeruli, so the curved cords of zona glomerulosa. What is blue here is capsule, and then we can see the septa in between. This figure shows the parallel columns of zona fasciculata and the sinusoids in between. And here an irregular network of cords in zona reticularis. And finally here, this area is medulla. Yeah, it's lighter and it contains larger veins. So now the blood supply. And we have talked about the blood supply already in arteries. So we know that we have the superior suprarenal artery. Usually more branches enter from above, and there are branches from inferior phrenic. Then we have a direct branch from abdominal aorta, which is the middle suprarenal artery. And then we have the inferior suprarenal artery, which is branch of renal artery. Then these branches into 50 to 60 cortical arteries, and they pierce the capsula and form subcapsular plexus. And from subcapsular plexus, we have 2 kinds of vessels. Either we have capillaries, and these capillaries form a capillary bed in the cortex, or we have perforating branches which continue directly to medulla. Yeah, the capillaries, they are of course sinusoids, and then in medulla there are smaller veins forming larger, and finally a central vein leaves the hilum as the suprarenal vein. And do not forget that based on a position of the inferior vena cava a bit to the right suprarenal vein drains directly into inferior vena cava, and the left drains into left renal vein first. So here we can see on the right side how the arteries come to the outer surface, and then they form the cortical arteries, and from cortical arteries the subcapsular plexus is formed. Okay, so when we get in, I said there are two kind of vessels. First are cortical sinusoids, which supply cortex, and the other are perforating arterioles. Yes, perforating arterioles, which just run down to medulla, and in medulla they form the sinusoids. So here both arterial and venous blood meet in one spot, and venous medullary plexus is formed, which finally unites into a central vein. So this is not a portal system, as we have sinusoids, and parallel we have the arterioles, and finally both open into or the sinusoids continue. Yeah, so we don't have two separate capillary beds, but we have one capillary bed, but into the one capillary bed the blood flows two ways, either via the perforating arteries or directly via cortical sinusoids into medullary sinusoids. Yeah, so this is not a real portal vein, a real portal system. Yeah, but here the blood to medulla it can bypass. You can see it here on this figure as well, when we have the cortical arteries and then the sinusoids, and parallel to it are the perforating arterioles, and finally they meet in the medullar sinusoid bed, yeah, and it drains into the central vein. So this is a view of your microscope, where you can see a lighter medulla and a darker cortex, and in cortex 3 layers. So we can mark the layers as the glomerulose, fasciculate, and reticular, and of course here we have medulla. Yeah, and you can see the tissue outside where there are visible adipocytes and some vessels. So on the surface we have quite thin capsule. And when we come closer, we can nicely see here the capsule, yeah, the glomerular zone, fasciculate, and reticular, and then lighter medulla with larger spaces, larger vascular spaces. So that's for histology. And now do not forget that the whole suprarenal gland serves for stress reaction. Yeah, so it is activated by the other regulation system, which is the autonomic nervous system, by sympathetic fibers. So, and this sympathetic activation activates this gland, but also it activates the whole body for the stress reaction. So smooth muscles in vessels, in organs, of course, but it has also some metabolic effects, mainly in liver. The glycogenolysis is producing glucose. Yeah. So, and finally, some pathological states. If we have a tumor in medulla, which is called pheochromocytome. It produces noradrenaline and adrenaline in boluses, yeah, in waves. So it can cause hypertension attacks. So this is quite pathognomic for pheochromocytome. For cortex, we can have hyper or hypofunction. The hypofunction is very easy to understand, that we don't have these hormones. It's called Addison's disease. You can see here Addison here. So Addison's disease, and the symptoms are quite non-specific. So the patient is fatigue, loses weight, and is not feeling well. On the other side, hyperfunction is quite specific, and it can be divided into hyperfunction of aldosterone. So then we have, it's called Conn's syndrome, and in the hyperfunction of aldosterone, of course, the patient suffers from too much too much sodium. That means too much water, so hypertension. And in edema. And then we have the hyperfunction for glucocorticoids, and it can be either the problem in the gland or the problem above the gland. That means at the level which regulates it in hypophysis. So adenoma of hypophysis is called Cushing disease, and when the problem is in the suprarenal gland, is called Cushing syndrome. And how does it look? You can see a typical patient with the Cushing syndrome, and such patient, you can see such patient also when corticoids are administered for a long time to the patient. And the main reason for that is that they are anti-inflammatory. Yeah, so corticoids as anti-inflammatory drugs are administered in case of autoimmune diseases, for example. So you can see that this patient suffers from obesity, but it's so-called central obesity with thin limbs. Yeah. Of course, high blood pressure. What you can see here are the striae, or in English, stretch marks, reddish stretch marks. They are quite weak muscles and weak bones, and the skin is very thin and fragile. Yeah? So this is so-called Cushing syndrome. And we continue into pancreas. And the pancreas is again a combined gland. And inside the exocrine pancreas, we have more than 1 million of pancreatic eyelids, which are very small. They are visible only by microscope. So they are 0.1 to 0.2 millimeter large. And they form only 1–2% of the whole tissue. And they are composed of different cells, and these cells each produce only one hormone. And the most important hormones are these four. So for regulation of the glucose in blood, it's insulin and glucagon, which changes the blood level of glucose, so glycemia. Yeah, the insulin takes glucose into the peripheral tissues, and the glucagon elevates the level mainly in liver by glycogenolysis, or also by production from amino acids. Then somatostatin and pancreatic polypeptide, which affect mainly GIT and the function of the exocrine pancreas. The somatostatin is inhibiting, and the pancreatic polypeptide is stimulating. So that's the introduction, and the history is also quite interesting. And already in old ancient Greek, the term diabetes was invented, which means to flow through. And Avicenna some 1000 years ago, he found out that the urine is sweet in severe diabetes mellitus, as there is a glucosuria. That means that glucose gets over the threshold for the kidney to reabsorb. And then finally, by microscope, it was discovered by Paula Langerhans 150 years ago. And then very nice experiments were performed by Benting and Best, who extracted extract from pancreas of dogs, and they then treated the dogs with this extract, the dogs with diabetes, and they find out that it works. So they did the treatment for the patient, and then Benting and another guy, McLeod, received the Nobel Prize for that. Yeah. So the anatomy of the pancreas is well known to you. So you know there's the exocrine and endocrine part all together. So it's a double gland located secondarily retroperitoneal in a duodenal window around vertebra L2, and it's supplied both from celiac trunk and superior mesenteric artery. So this all you know. And as I said, we cannot see the eyelids by naked eye. The whole eyelids, the million of them, its weight is only 1 gram. But if we remove pancreas, we have to totally supply the hormones, and the most important is of course insulin. Yeah? So when we see on the eyelid, you should talk about the development. Yeah? The development is very easy. They are derived from the same tissue as the exocrine, so they come from endoderm, from the foregut. They just they were formerly acini, but they lost their ducts, so now they are cells without ducts, so they have to secrete into the blood, yeah? And they form such clusters which we call eyelids. Okay, which are the types of cells? So we use now the letters for them. So the A cell produces glucagon, and you can see that there are granules inside. The dimensions of the granules is from 150 to 300 nanometers. So they are visible by electron microscope. And as I said, the A cells produce glucagon, and what is important, they are found at eyelid margin, so they are located peripherally, yeah? And they stand for 20% of the cells. B cells are the most common. They create 70% of the all number of the cells in the eyelid, and they are located in the center, yeah? And they produce insulin. So what we can see here is a specific immunohistochemistry staining for the glucagon, as it's located in the periphery. Yeah? Here again, nicely visible in the periphery. So another are D cells producing somatostatin. As I said, somatostatin is inhibiting one, and it's produced to regulate the exocrine pancreas, so the acini, by one long process. So it's a paracrine secretion. And then we have F cells, which used to be called the PP cells. They produce the pancreatic polypeptide for the regulation of the pancreatic exocrine part in sense of stimulation. And we have other cells which are quite scarce. D1 producing the vasoactive intestinal polypeptide, and EC cells producing secreting motivating substance P. Then we can have very rare G cells, PYY, and ghrelin secreting cells. Yeah, but they are not so important. We can have tumors of these, and mainly important are tumors which are called insulinome. So insulinome then produces too much insulin, So the patient suffers from hypoglycemia. Yeah, that's very important. So where are the eyelids located? They are located mainly in the body and tail. And also for the cells, it's different. In body and tail, we have more of these B cells producing insulin, but in the head, we have more these F cells producing pancreatic polypeptide, of course. Yeah. And as I said, the B cells are in the center, and A, D, and F or PP cells are in the periphery. Why it's like that? Because we have here something which is called insulo-acinar portal system. So I said that we have the B cell here and the A cell here. So the A cell produces glucagon, then the glucagon come here and produces the function of insulin as well, because when we start to produce glucose into the blood, then we need to get the glucose again into tissues. And then it continues from endocrine to exocrine, so the pancreatic polypeptide can be taken to the exocrine part. Yeah, so when we have here the F cells, then it's taken again here. So we do not call it portal system, we call it insulo-acinar, sometimes portal system. Yeah, as we have, of course, vessels which supply only the exocrine part. So you can see that suprarenal gland and pancreas, as they are double glands, they have quite specific arrangement of the vessels. And from your microscope, you can see here septa in the exocrine part between the acini, pancreatic acini, and then in the middle, you can nicely see, just circle it. We can see the Langerhans pancreatic eyelid here, for example. Yeah. And when we come closer, you can see how it's lighter and there's not the arrangement of acinus. It forms a cords which are stick to each other. When we use pus, they are again lighter. So you can see them, for example, here. Yeah, more of them visible. Of course, we nicely see vessels. So that's for pancreas. And if, as I said, if you like to see which cells produce which hormone, we have to use immunohistochemistry. So here we see quite high activity in the pancreatic islets and vessels in a septa of the exocrine part. So we have talked about the development already. This is what I said. The development is similar for exocrine and endocrine. They are just separated from ducts, so they lose them. Which cells appear first are A cells, but even the A cells start to produce glucagon later in the 15th week. The B cells starts to produce insulin from the 10th week. Yeah. So that's important information. Insulin is produced from the 10th week of the development. And here, just to conclude, there exists multiple endocrine neoplasia, which means that 2 or 3 endocrine gland tumors can appear. It is usually hereditary syndrome, so it's called a Mann syndrome. And you can see just for example, to understand how it can be complicated, that if you have a tumor of endocrine gland, you have to look for a possible existence of other tumor, yeah, due to this Mann syndrome. So you can see that the Mann syndrome number 1, it's a carcinoma of the parathyroid gland, pancreas, and pituitary gland. 2A is the thyroid gland medullary carcinoma, pheochromocytoma from the medulla of suprarenal gland, and carcinoma of parathyroid gland. Yeah. So there exist these complicated hereditary man syndrome. So please remember, when you have a tumor in endocrine gland, try to look for some other endocrine gland tumor if it's not present, but as it can be. Okay, the last organ is called pineal gland. The pineal gland is located in the brain. You would say, well, why inside the brain is a gland producing hormone melatonin? So we can see here a terrier living in New Zealand in the Northern Island. And here you can see the opening of the skull, which is located between the parietal bones. And it allows the polarized light coming from moon to affect this gland, which then produces the hormone of sleep, melatonin. Yeah. So we don't have the parietal eye, unlike arterias, but we still have pineal gland producing the hormone. Yeah. Epiphysis, as it grows up, unlike the hypophysis, which grows down. It is an old term which is not used, should not be used anymore. Yeah, we just call it pineal gland, according to the shape, which is similar to a cone of pine. So where it's located? It's located behind the upper posterior end of third ventricle. So the hypophysis is below the third ventricle. This is above and behind. It is not part of hypothalamus, it's part of epithalamus. And it's a bit rudimentary gland, and it has suppressive effect on sexual glands. Yeah? So it can cause, in hyperactivation, it can cause puberty which comes too early, pubertas precox. Yeah? It produces melatonin, and from the age of 20 to 25 we can find calcium concrements inside, which does not make problems, but they can be found there, and we call them acervulus, which means a brain sand. Okay, so this is basic information. We will talk about the pineal gland then later in CNS again, but it's fine to know now when we talk about the endocrine gland. So we can see it here, how it's located dorsally and above the third ventricle. When we look from above, we can see it here, yeah, behind the third ventricle, in front of cerebellum, and close to these four tubercles, which we call a quadrigeminal plate, which is part of the mesencephalon, midbrain. Okay, here we can see it on a median section. On this median section, this is the pineal gland, yeah, and this is thalamus and hypothalamus, and this is midbrain. So we can see it here, and I think this is a well-known vessel for you, as it's a great cerebral vein of Galen. It originates from the internal cerebral vein, and this is the great cerebral vein. So that's for the orientation. And it was thought in mechanical philosophy that the pineal gland is a seat of soul as well. Yeah, we know now that it's not a seat of soul. We know that it's an organ which receives information from retina and hypothalamus, and then it can produce melatonin. So what you can see here on this transverse CT of the skull. Of course, frontal sinus here ventrally. Then some pathological structures here. Yeah, but what we can see here is the calcium concrements in pineal gland. Yeah, just here in the midline. So this is normal. And we come here again. Here. concrement in pineal gland. This is concrement in choroid plexus. This also can be considered normal. And this is, of course, something pathological. And we should know about that as it should be in midline. If it's not in midline, it's a sign of compression of one side by some pathological process in the other side. Yeah, so this should be all the time in midline. As you can see here again, here in the midline, the pineal gland, here some pathological structure in the lateral ventricle. And here in the midline, this is MRI, but here in the midline you can see this is a tumor of pineal gland, pinealoma, yeah, which then compresses, usually can compress the ventricular system. So histologically, what is it? It's covered by a pia mater, yeah, which is the innermost layer of the meninges. It again produces septa inside, and the cells are pinealocytes. Yeah, and the pinealocytes, they produce melatonin and some other neuropeptides, but mainly melatonin. Melatonin is higher during night and lower during the day. Yeah, so it's a hormone of sleep. And between pinealocytes, of course, there should be some astrocytes, which are called interstitial or astroglial cells. So that's pineal gland in short. And if you look at the pineal gland, you can nicely see the pinealocytes. And here on the surface is a cover of the pia mater. And as I said, what is really pathognomic for that is the brain scent, acervulus, or also a term in Latin which is used is corpus arenaceum. Both means a scent. And as I said, after the age of 20, it starts to appear there as in extracellular protein material, which is then filled with calcium. So you can then see it within the tissues. Yeah. So it's like prostatic concrements, for example, also appears there and not producing any problems. So we have stopped the topic of endocrine glands as organs, and now do not forget that the organs, of course, produces hormones as a side functions. So, for example, adipose tissue produces such hormones. But we should talk about heart and kidney. In heart, in atrium, the cardiomyocytes, which are also mechanoreceptors, as you know, they produce atrial natriuretic peptide or factor. And this, as it's called natriuretic, is the only hormone which allows us to increase the excretion of sodium ions. Yeah, so then we lose sodium, we lose water. So they help us to relief of hypertension. In heart ventricles, the cardiomyocytes, they produce BNF or BNP, brain natriuretic peptide. But if this is used much more as diagnostic marker, the higher plasma concentration appears in heart failure. Yeah. Okay, then kidney. And in kidney, of course, we know that kidney produces erythropoietin. Erythropoietin is produced in peritubular interstitial cells of cortex. And you can understand from the name what is the function. The function is erythropoiesis alignment. Yeah. So it appears when we have hypoxia in kidney, of course. Yeah. So that's the main function. And of course, it is used as a substitution treatment, but it's abused in sports, yeah, as it causes larger amount of erythrocytes circulating. So do not forget about erythropoietin. And of course, in kidney, we have the production of renin, and we have already talked about that we have the renin, angiotensin, aldosterone axis. Yeah? How it works? It works, it starts in distal convolute tubule where we have macula densa. So macula densa is a chemoreceptor, and this chemoreceptor finds out what is the situation with sodium and chloride ions, and if it's not relevant, then by activation of extraglomerular mesangial cells, which interconnect the macula densa with afferent and efferent arteriole. It stimulates the cells of media of these arterioles, and these cells are called granular cells as they contain granules of renin. These cells also works as mechanoreceptors. So in case we have hypertension, we have more blood and more water, and so we have also more sodium. We find out both by mechanoreceptors in the wall and directly by the chemoreceptor, the macula densa in distal tubule. We find out this information, and we start to produce renin. Renin comes into, so now we have renin produced, yeah, peptide. The renin comes into blood, and in blood, the renin changes an angiotensinogen produced in liver, yeah, into angiotensin 1. Angiotensin 1 is a weak vasoconstrictor. Yeah? Angiotensin, angion is a vessel, and tension, you understand, is a constriction. It comes to lungs, and in lungs is a special enzyme on endothelium which is called ACE. And this ACE produces angiotensin 2, which is a very, very powerful vasoconstrictor. So now we have vasoconstriction, and this vasoconstriction then works together with another function of angiotensin, which is in suprarenal gland in the zona glomerulosa, a production of aldosterone, and the production of aldosterone then increase the fluid volume. Yeah. So then the whole apparatus, which is called juxtaglomerular apparatus, can tell you about the situation of the volume and the content of sodium and chloride ions, and regulated via this renin, angiotensin, aldosterone axis, RAA, which is very used in clinical practice to understand this axis. Yeah, and it can be in hypertension. It can be influenced by ACE inhibitors. Yeah, ACE inhibitors are quite mighty medicaments against the hypertension. So please remember that renin is produced in kidney as well. And the whole axis is here again, so you can go through that in detail at home. Here, of course, nothing new for you, juxtaglomerular apparatus, yeah. So the macula densa and the extraglomerular mesangial cells, sometimes called Lassie cells, and then the granular or juxtaglomerular cells of media of the arteriole, afferent and efferent arterioles. So, last topic are paraganglia. What are paraganglia? They are, as for the structure, quite similar to ganglia, to the groups of pericardia outside CNS. And we divide them into chromafine and non-chromafine. That means these which are stained and these which are not stained. The chromafine used to be called sympathetic paraganglia, non-chromaffine, parasympathetic. The non-chromaffine are easier as they serve as baro and chemoreceptors, and you already know them as they form the carotid body and aortic body. Yeah, aortic body and carotid body. So they serve for the blood pressure and they perceive a level of oxygen. And they are composed histologically of glomocytes, which are the receptor cells. And then we have these chromaffine. And these chromaffine, they are very similar as suprarenal medulla. But suprarenal medulla develops slowly, so they serve as functional suprarenal medulla during the fetal and early postnatal period. Yeah, and then they are replaced by suprarenal medulla and they fade out. We find them very close to suprarenal medulla, so the most well-known is so-called Zuckerkandl's abdominal aortic paraganglion. But we have one in front of the tip of coccyx, and then we have some smaller ones along the vagus and glossopharyngeal nerve and its branches. So we have a jugular glomus, tympanic, sorry here I miss letter P, tympanic, vagal, laryngeal ones. Yeah. Why you should know about them? We should know about these as they can change into tumors, and the paraganglia can be very, very dangerous for the patient. Yeah, they can be malign. So here we can see how the abdominal aortic suckercandlous paraganglion looks like, yeah, like horseshoe shape, and it's at the origin of inferior mesenteric artery, and it usually fades out until the 5th to 6th year of the development. And this is just how the paraganglion looks like from the histological point of view, but we can leave this to histology. The last slide is not about endocrine organs, but only about the endocrine cells. And we know that these cells, we call it disseminated endocrine cells, or DES system, or it used to be called DNES, or APUD, yeah, which means diffuse neuroendocrine system, and APUD means amine precursor uptake and decarboxylation. And after you ask why you should know these, you should know these as the tumors from these cells are called apodoms. Yeah, so the tumors are called apodoms. And of course, you know these cells as the cells of the DES system are the paracrine cells of small, large intestine and stomach, and they affect their vicinity. We can find them in the respiratory tract as well. And there are many hormones produced, and we have talked already about some of them, like cholecystokinin, pancreatic polypeptide, and vasoactive intestinal polypeptide, gastrointestinal polypeptide, motilin, substance P, and so on. So do not forget that also within the epithelia of GIT and respiratory tract we find this disseminated endocrine cells. That's all for today. Thank you very much for paying attention, and I'm again sorry for the technical problems which I had, and have a nice day. Goodbye.